this course. In this part, I will mention other entities of ectatic corneal disorders, including Fruste keratoconus, Pellucid marginal degeneration, Pellucid-Like Keratoconus, Keratoglobus, and Ectasia. I hope you will enjoy.
In the last videos, we talked about keratoconus, but it is very necessary to mention other entities. We have to talk about Fruste keratoconus, Pellucid marginal degeneration, Pellucid-Like Keratoconus, and Keratoglobus. And we have to know something about iatrogenic ectasia. Starting with Fruste keratoconus. There are two definitions of Fruste keratoconus. The first definition is we have a very normal cornea. There are no abnormalities and no risk factors on the topography and tomography in one eye, but the other eye has a frank keratoconus. In this case, the normal eye, as in this example, the right eye, is considered as Fruste keratoconus, which means that it is prone to have ectasia if we do any keratorefractive surgery on the cornea. The other definition is an abnormal cornea that has abnormalities, but those abnormalities are not sufficient to classify this cornea as having frank keratoconus, and at the same time, it is not normal cornea. Pellucid marginal degeneration. In pellucid marginal degeneration, we find focal thinning in the inferior part of the cornea as a strip extending horizontally but with a clear area at the limbus. On corneal tomography, we find the claw pattern or crab claw pattern or the kissing bird sign on the curvature map, but this sign is not a hallmark for pellucid marginal degeneration since it is seen in another entity called Pellucid-Like Keratoconus, as we will talk later. But the hallmark of pellucid marginal degeneration is the bell shape on the pachymetry map. As you see here, it is the bell shape. In addition, the cone apex in pellucid marginal degeneration is just above the area of thinning, contrary to what is seen in keratoconus. In keratoconus, the thinnest area is or corresponds to the apex of the cone. Here, the cone apex is just above the area of thinning, and this is called the beer belly side profile. If we see the pattern, fluorescein pattern, with the contact lens, we can see the bulging in the inferior part of the cornea because it is peripheral ectasia. And we can see on placido the elongated rings in the vertical direction because there is an against the rule astigmatism. In the thickness profiles, we see the inverted shape, which is a hallmark also for pellucid marginal degeneration. Pellucid-Like Keratoconus. In Pellucid-Like Keratoconus, we may find the crab claw pattern on the curvature map and the kissing bird on both elevation maps, but for sure, we should not find the bell shape on the pachymetry map. Otherwise, it is pellucid marginal degeneration. And on the thickness profiles, we see the S shape maybe, or the rapid flow of or the rapid slope of the red curves, similar to what's seen in keratoconus. We have to differentiate between pellucid marginal degeneration and Pellucid-Like Keratoconus because the indication of treatment may differ. Let's have an example of intracorneal rings because if we indicate intracorneal rings in pellucid marginal degeneration, there are special considerations to avoid perforation of the cornea because we may insert the intracorneal segment into the very thin area, while in Pellucid-Like Keratoconus, most probably we are away from the thinnest location. And of course, there is a difference in the indication of penetrating keratoplasty or lamellar keratoplasty in these entities. Keratoglobus. Keratoglobus is a generalized bulging or generalized ectasia all over the cornea, as we see on the curvature map and on the pachymetry map. We can see generalized thinning on the pachymetry map reaching the limbus. This is the pachymetry map. And also we see an irregular thin cornea on the OCT. And the Scheinflug image can show us also the generalized thinning of the cornea and the outbulging. It's helpful to read this table, which differentiates between pellucid marginal degeneration, keratoconus, and keratoglobus in terms of the etiology, onset, location of thinning, location of protrusion, scarring, clinical presentation, signs, and topography. The etiology is unknown in all these entities. In pellucid marginal degeneration, the onset is usually around the second to the fifth decade of life, while in keratoconus it is around puberty, while in keratoglobus it is at birth. So it is a congenital defect in the cornea. Location of thinning, it is 1 to 2 millimeter from the limbus. In pellucid marginal degeneration, it is central or paracentral in keratoconus, and it is generalized in keratoglobus. The location of protrusion is superior to the thinning, which we call it the beer belly side profile in pellucid marginal degeneration, while it is apical and corresponds to the location of the thinning in keratoconus, and it is generalized and globular in keratoglobus. Scarring is absent in pellucid marginal degeneration and in keratoglobus, while it is present sometimes, it is present in keratoconus. The clinical presentation comes, the patient comes with reduced visual acuity due to astigmatism and rarely from hydrops in pellucid marginal degeneration, while in keratoconus we have usually asymmetrical reduction of visual acuity due to myopia and astigmatism, or sometimes due to acute hydrops in keratoconus. And in keratoglobus, the patient comes with rupture with any minor trauma, and very rarely we have acute hydrops. In pellucid marginal degeneration, we can see the beer belly and the band thinning in the inferior part on the slit lamp, while in keratoconus we see the conical ectasia and the V shape that the inferior lid takes, which we call it the Manson sign, and we can see the Risotti sign, we can see the Fleischer ring, and the oil drop with retinoscopy, and the scissoring reflex also with retinoscopy. The oil drop can be seen by the retroillumination also. While in keratoglobus, we can see a globus ectasia. On tomography, the hallmark of pellucid marginal degeneration is the bell shape on the pachymetry map. The crab claw can be seen on the curvature map, but it is not a hallmark because it can be seen also in pellucid-like keratoconus. In keratoconus, we can see different shapes on the curvature map, like the irregular, the asymmetric bow tie, the skewed radial axis index, the hot spot, inferior steep, superior steep, and many different shapes that we talked about previously. In keratoglobus, we can see generalized steepening on the curvature map and generalized thinning on the pachymetry map. Iatrogenic ectasia. The new definition of ectasia is increasing myopia with or without increasing astigmatism, with loss of uncorrected distance visual acuity and often loss of corrected distance visual acuity, with keratometric steepening, with or without central and paracentral corneal thinning, and topographic evidence of asymmetric inferior corneal steepening. Now, this leads us to the progression indices in ectasia and in keratoconus. How to say that this patient has a progressive pellucid marginal degeneration, keratoconus, other entities, or he has a progressive ectasia. Now we have to say that the progression indices have been a place of big debate between surgeons, and that's because there is no 100% of reproducibility of corneal maps in any machine. We have very high reproducibility in the Pentacam and other machines, but it is not 100%. Now, what does that mean? It means that sometimes we can take the picture of a patient and we see that his Kmax is 50 diopters. Then we take another capture of the patient after maybe 2 hours, and we can find it maybe 1 diopter more or 1 diopter less. And if we repeat this maybe after a few days, we may find also a bigger difference. And one of the studies that was presented in the last conference of the 10th International Congress of Corneal Cross-Linking in Zurich 2014, this study stated that there is a difference of about 2 diopters in Kmax between captures of the same patient, which means a very big standard deviation. However, the criteria of progression that are mentioned in the literature are when we have a difference in Kmax of equals to or higher than 1 diopter, if we have a difference between Kmax and minimum K in the same cornea, which is equal to or higher than 1 diopter, if we have a change in the average K equals to or higher than 0.75 diopters, if we have a decrease in the pachymetry equals to or higher than 2% in the central corneal thickness, and if the corneal apex power changes by more than 1 diopter, and if we have a change in the manifest refraction spherical equivalent higher than 0.5 diopters over 6 months of follow-up. Now, what's important here is we cannot depend on only one of those criteria. I mean, we cannot depend on the change in Kmax, just Kmax. So we have to have at least 3 indices that have changed over the 6 months, at least 3 indices. The best way to find the changes is to use the difference map on corneal tomography, because it shows us the changes in numbers and in the shape also. Now let's talk about the risk factors of ectasia. We have two paths, the LASIK-related path and the disease-related path. The LASIK-related path is related to the thickness of the flap and the ablation depth and the residual stromal bed. Of course, if we have very thick flap or very deep ablation or very thin residual stromal bed, we have very high risk of developing ectasia. And the disease-related path includes any abnormality in corneal tomography and some other abnormalities that we will be mentioned now prior to doing the surgery. Now, let's start with the LASIK-related path. To have an idea, let's discuss the decrease in corneal strength after photorefractive surgeries. It has been found that the corneal strength decreases by 5 to 10% when we do surface ablation, such as PRK, trans-PRK, epi-LASIK, subbowman keratomylosis. But if we go for the lamellar ablation, like LASIK and femtolasic, the reduction will be between 10 to 30%. And this depends on the thickness of the flap. When we have an 80 microns flap, the reduction is about 14%, while if we have very thick flap, such as 180 microns, then the loss will be about 33%. In addition, the disease-related path has very big role on the development of ectasia, like the prominent corneal nerves, the Sisering reflex, Fleischer's ring, abnormal topography patterns prior to surgery, Vogt's striae, focal thinning, asymmetric steep cornea. Asymmetric steep cornea means the difference in Kmax between the two corneas of the same patient. If the difference between both eyes equals to or higher than 1.9 diopters, then it is a risk factor. The same for the asymmetry and pachymetry. If we have an asymmetry between the thinnest locations in both eyes equals to or higher than 30 microns, then it is a risk factor, because it has been found that less than 5% of normal people have more than 25 microns difference, and less than 0.5% of normal people have more than 34 microns. So in average, we can say if we have a difference equals to or higher than 30 microns, then it is a risk factor. Also, the asymmetric astigmatism, asymmetry of refraction. If we have an asymmetry of refraction between both eyes more than 1 diopter, it is a risk factor. And if we have suboptimal corrected distance visual acuity, if we have no other explanations involving the lens or the vitreous body, the retina, the optic nerve, if we have a family history of any ectatic corneal disorder, if we have a history of constant eye rubbing, if the astigmatism is irregular, if there is an apical scarring, and if the cornea is thin, and I have defined the thin cornea in previous videos. And finally, if we have abnormal shapes on the elevation maps using the best fit sphere reference body. Now, in order to predict the risk of developing ectasia after photorefractive surgeries, There are two major scoring systems. The oldest one is the Tabbara scoring system. It grades the cornea from 1 to 3, depending on the keratometry, oblique cylinder, central corneal thickness, posterior elevation, inferior superior difference, and the ratio between the ratio of posterior best fit sphere, anterior best fit sphere. The other scoring system is the Randleman scoring system, which grades the case from 0 to 4, depending on topography, residual stromal bed, age, central corneal thickness, manifest refraction spherical equivalent. And after scoring the case, we go to the cumulative risk in order to see the total risk score and the ratio of risk, and we have some recommendations. Finally, I would like to say that we should not rely completely on these scoring systems. We can have an idea, but we have to depend on our skills of interpretation of corneal tomography, which is the main goal of this course. By this, we finished diagnosis and classification section, and next time we will start with section 2, management modalities.